We were consulted on a 62-year-old female obese patient for acute respiratory distress and ultimately failure. She has a significant past medical history of hypertension, type 2 diabetes, hypothyroidism, and hyperlipidemia. She initially came into the hospital on June 28th for removal of infected hardware in her right lower extremity. She did get that hardware removed. Last night, she became more hypoxic, tachypnic, tachycardic, febrile. She was transferred down to the intensive care unit where BiPAP was initially tried to correct her respiratory issue. That failed and she was ultimately ventilated. Her white count this morning is 30,000. Her hemoglobin is 10.5. Her platelets are 183. Creatinine is elevated at 2.4. Procalcitonin was 4.27. CT of the chest was performed early this morning, shows ground glass opacities, bilateral infiltrates, bilateral lower lobe pleural effusions. The patient is currently sedated. Vital signs are stable at present. She has a past medical history of hypertension, type 2 diabetes, hyperlipidemia, hypothyroidism. Her review of systems is difficult to perform. However, she constitutionally appears gravely ill. She has 3+ pitting edema everywhere. Her Foley has dark concentrated urine in the bag. She is sedated and she has a petechial rash all over her arms, legs, chest, back. The right lower extremity has a wound vac in place, and there's green, yellow colored drainage in the tubing. Physical exam, vital signs are stable except for her temp was 102.4, for which she has received Tylenol rectally. She is currently intubated. She does not follow commands due to sedation. Cardiovascular, she has a regular rate and rhythm. S1 and S2 are heard. The neck is supple. Trachea is midline. Respiratory, she has coarse, dim breath sounds throughout all lobes. Neurologically, she is sedated. Bowel sounds are present. She has an OG tube in place. Feeding has not been initiated yet. She has the rash as mentioned, no jaundice noted. Her assessment and plan, she has acute hypoxemic respiratory failure. She is ventilated and compliant with settings maintaining an oxygen saturation greater than 90% on those settings. We're thinking hospital-acquired pneumonia because of the results of the CT from this morning. The patient is currently on vancomycin for her right lower extremity wound. We're going to add Levaquin and aztreonam for the lung infection. The patient does have a history of allergic reaction to penicillin. Sputum culture has been ordered and is still pending. I want the sputum culture to be obtained and sent prior to the other antibiotics being initiated. She has pleural effusions, ventilator. She is ventilated. I ordered an echocardiogram. Severe sepsis. We're thinking source of infection is that right lower extremity. In addition, she has a urinary tract infection, so we're thinking it's a combination of the two that has brought her to this state. Acute kidney injury, secondary to acute tubular necrosis and sepsis. We discontinued the lisinopril, started her on Lasix. Type 2 diabetes, the patient is to continue on the insulin sliding scale. She is currently NPO. Hypotension, she has a history of hypertension. Meds will not be restarted for that until the hypotension has been corrected. She is receiving the fluids, 30 mg per kg, as per the sepsis protocol. DVT prophylaxis, she does have a petechial rash, and we are concerned about disseminated intravascular coagulation. However, we're going to start her on heparin 5000 Q8 for prophylaxis, as she does have history of DVT.